Okay, again, so welcome to today's session on telehealth and advocacy. Thank you, Emily. She's advancing the slides for me. Okay, so this webinar is being brought to you by the Guam Coalition Against Sexual Assault and Family Violence. And Calcasa is excited to be here and be able to help provide this webinar on behalf of the Guam Coalition. The project is being supported by a grant from the Office on Violence Against Women, U.S. Department of Justice, and also awarded by the Family Violence Prevention and Services Act, Administration for Children and Families. Okay, so part of this series also we have a few more webinars of this month of November, and then starting in December, we'll have more. So these are just some dates for you all to keep in mind. And you can also find more information about these webinars on the Guam Coalition website, which is guamcoalition.org. Okay, so many of us are probably already familiar with the Zoom platform, but I do just want to do a quick run through of what you have available on today's session. As many of you know, we have the text chat feature, which is in the bottom of your Zoom window. So feel free to use this for any of your responses, or if you have any questions, you may also use the text chat for that. The PowerPoint slides that you're seeing on your screen, those will be made available to you as well. So following the session, you'll receive those. We do have a few polling questions today, so those will appear on your screen, and then you will be able to interact with the polling question from your device. If you're having any Wi-Fi or internet issues, you should be able to dial in by phone in order to join the session. That way you can hear the audio. And so the numbers for the dial-in phone number should have been sent with your registration confirmation email. We do also have closed captioning available. So in the bottom of the Zoom window, next to where you see your chat and participants button, you'll see where it says closed caption or CC. You can click that and then the caption should appear on your Zoom window. And as far as guidelines, feel free to use the hand raising feature if you want to chime in about anything or ask any questions. And you can find that feature on the participants list in the bottom of the window that pops up when you choose participants. So again, my name is Shelby Phillips, pronouns she, her. I am the project and communications coordinator at Calcasa. So I will be on this session for any technical support you may need, and I'll also be monitoring the chat. So if you have any questions throughout, feel free to drop them in the chat. And also you can send me a private message if there's anything that comes up as well. Okay, so without further ado, I'd like to introduce our presenter for today, Emily Austin. I'll pass her the virtual mic and let her take it from here.
Good morning, everyone. I'm Emily Austin, a legal consultant for Calcasa. My pronouns are she, her, hers. And I'm excited. This is the last of several webinars I've been able to do for the Guam Coalition, and I'm excited to focus a little bit on online advocacy and the idea of telehealth and how that connects to supporting survivors of sexual assault and domestic violence. So today we're going to look at different forms of telehealth. It's not just Zoom calls. It's actually a very broad bunch of tools that you can use as an advocate and start to think about best practices in providing telehealth services to survivors of violence. So I wanted to start personally just taking a temperature of how are you feeling? How ready are you individually to be able to provide telehealth? Let me launch this poll. Let's see how folks are able to, how ready are you personally to expand? into telehealth. It's missing a little bit of this, of the final part of the sentence, but how ready are you to personally expand your work into telehealth? Some of you may be already doing it, given our current climate and situation. Great. I'm going to show you the results so far. It looks like a lot of you already are feeling confident or have already done some forms of telehealth. See, 29% of us are more than 75% ready to do this type of work. And then only 14% of us are more at the under 25% readiness. I want to ask next another question that's specifically to what do you think about your organization? So no matter what organization you're working at, how ready are they to intervene and support survivors or individuals through telehealth? Let me launch this poll. So this is about your organization, not your individual readiness. I think some of us have noticed a big change given COVID and the limitations on being able to meet person to person. Great. So how ready is your organization to expand into telehealth? Great. Got about 70% of us reporting. Let me share these results back with everybody. Great. So we see there's a little less, of that very confident readiness. 0 people, organizations feel more than 75% ready. But we do see that in the middle, there is significant number of organizations that feel more ready into doing online advocacy and providing forms of telehealth. Great. So we're going to revisit this question at the end and see if there's been any shifts. Hopefully today you'll get to learn more about what is telehealth and kind of how I'm using it in this webinar, and understand some of the best practices there are for providing really timely and effective forms of advocacy and support to survivors in various forms through telehealth. And then I want to talk about a lot of the telehealth modalities. So online, text chat, messaging, these all are slightly different and they have different kind of concerns or best practices that are associated with them. And then finally, I want to talk about protecting confidentiality while using telehealth approaches. Because if you're functioning under a Violence Against Women grant or a Victims of Crime Act grant or various other provisions or requirements such as being a doctor or nurse, there are confidentiality provisions that want you to keep information as confidential as possible. And a lot of folks can be nervous about moving into telehealth and compromising that confidentiality. So we'll talk about that as well today. Here's a little roadmap. I'm gonna introduce telehealth and the concepts. We're gonna talk about it in small groups a little bit. We're gonna talk about the why even provide telehealth services. What are the formats? What are the modalities? Then how does telehealth exist in a landscape where there may be conflicts of interest or confidentiality concerns, privileged communications? And then finally, we'll talk about some general best practices for online advocacy and telehealth. So first, I'd love to hear a little bit from the group about your experience providing telehealth. Have you provided any direct services to survivors or other folks through online advocacy or telehealth? If you want to drop that in the chat, I'd love to get a feel for kind of what services are looking like for you during these times. All right, go ahead. If anyone has provided services, I just want to add a couple more co-hosts on here. 1 minute. Okay. Maybe folks haven't really used telehealth yet in providing services. In the States, in the United States, and where I've been working in California, we've seen a big shift since the COVID-19 epidemic. Whereas before, most of our services were provided face-to-face, where people came in, maybe they called first over the phone, but then they came in for intake, they came in for counseling and support services, or advocates showed up to forensic exams and to investigative interviews to support survivors face-to-face. During the pandemic, the initial days, we saw a big shift in how to respond to survivors, and we were able to pivot quickly because telehealth has been around for a long time. So advocates in California were able to pretty quickly adapt in some skills and practices to bring online advocacy and telehealth to the different communities and survivors that we're working with. And at the same time, that face-to-face connection is still needed. So we see our centers still trying to provide ways to provide safe face-to-face advocacy and support and therapy. But telehealth is a bridge. It's a bridge, and for some survivors, it's the best way to provide support during these times and even outside of these times. Great. We see that a few of folks have been advising different ways of self-care to people on the hotline. And I think that actually underscores a really big piece of telehealth is that telephone is part of the initial kind of old school form of online advocacy / telehealth. It's a way to connect with people across wide distances, and you're able to provide a lot of support. Remember during Sexual Assault 101, when we looked at that listening as a key bridge of responding to a survivor. And that listening can happen through telehealth, through Zoom calls, through phone calls, through online text and messaging. All right, so telehealth is, I'm going to provide a more general definition here for our talk today. And it can be called things like online advocacy. It can be called, video facilitated support, anything that is using technology. For today, we're kind of thinking about telehealth as the distribution of health-related services and information through electronic information and telecommunication technologies. So using these type of technologies to provide health-related services and information. And some of the reasons for telehealth and where it was developed was connecting to people in rural settings. And that includes a lot of island cultures and island settings. Lack of transportation when it's very hard for people to get to face-to-face meetings. A lack of mobility when a person can't physically move and get into a car or use transportation to get to a place, decreased funding, reduced staffing, or what we've are experiencing now, stay-at-home orders and restricting access to care. And telehealth is proving to bridge that gap and is proven to be efficient. I want to pause here because I think it's important that we consider telehealth not just providing counseling services through a video Zoom, but telehealth is much bigger than that. It encompasses telemedicine, which is diagnosis and treatment of illnesses or injury. So that's actually having a doctor be in contact with a client or a patient and be able to help diagnose an illness and tell them what to do. We're seeing a lot of that when people think they have symptoms or test positive for COVID-19. Doctors are utilizing telehealth to talk to patients and make a plan of action, whether they're going to stay home and take care of themselves there, or whether they're going to come into the hospital to seek support there and medical care there. Then there's services such as assessment. So we see that with COVID-19 as well. We see doctors assessing how dangerous, how severe the infection is, and making calls based on the assessment. We see it also used in mental health services, such as providing, assessment around suicidality risk or level of depression, using telehealth to assess what the patient survivor needs. Then we have the use of telehealth for monitoring. And that means like ongoing care and tracking. You see this with dialysis patients where they're tracking insulin levels over time using technology that they may share in real time with their doctor. Then there's the final three, which get to more softer skills around telehealth. One is communications, which increases the ability to talk to professionals, reduces isolation, and communication can be really important around all forms of mental health support. Then there's prevention. So we're seeing now that Department of Education, that various anti-violence prevention programs are using telehealth and online advocacy to continue to forward prevention work, prevention of violence, prevention of hunger, improving shelter. All these kind of preventative focuses can be done through telehealth and online advocacy as well. And then finally, education. We see that health-related education is happening from our online health classes at our schools to our rape crisis centers and response centers that are providing sex education to students online. We see that telehealth is a great way to get to prevention and education, as well as the more medical diagnosis and treatment of illnesses. So telehealth is much bigger than just diagnosing an illness. It includes communication, prevention, and education. So the next piece is really the why. And I don't like to do anything without kind of understanding why it's important and why it aligns with our values as advocates to end sexual violence. What I want to do now is break you guys into groups of about 4 to 5 people for about 15 minutes and talk about why should people that work with survivors of sexual violence provide telehealth services to survivors. And then what are the challenges and opportunities of telehealth for people working with survivors of sexual violence and just in general. So I'm going to break you all into groups right now and put these questions into the chat. Let me put them into the chat first. So the first question is, why should advocates provide telehealth to survivors? And then what are the challenges and opportunities of telehealth. And you'll be asked to join a breakout room for about 15 minutes in 1 moment. All right, here we go. I'm going to open all the rooms now, and then I'll broadcast a 2-minute reminder to let you know to wrap up your conversations, and we'll come back together. So remember, why should we provide telehealth to survivors of sexual assault? And what are some of these opportunities and challenges of working with survivors in telehealth? Great. Well, I think most folks are back from the breakout rooms. I have a couple ideas already in the chat, but if you had any pros and cons of telehealth that you talked about that want to share, you can either unmute or add them into the chat and we can brainstorm together what are some good things about telehealth and what are some challenges with telehealth for survivors. Oh, Carmela, why don't you go ahead?
So in our in our group we actually talked about it. It's a little different. We think it's just for Guam. The challenges, of course, are not everyone have the resources. But as far as why should advocates provide telehealth to survivors, one of our group members basically mentioned that she would use the telehealth to survivors as a follow-up and not an initial. I know this is, such a different time that we need to get accustomed to, but I personally haven't used telehealth for survivors. Face-to-face has been the ideal. And now that there's Zoom, I think it is a plus, but yet for those that don't have the resources, it may be difficult for them to reach out or for us to reach out.
Yeah, you have to basically have some sort of phone or laptop for a Zoom call or for a video call. You have to have access to internet, and it can't even be just like dial-up speed. It has to be you have to have access to some strong technology to make it feel not so disjointed. So I think that digital issue is definitely one. It's one I think a lot of communities face.
Right. And then I see some pros on the chat. So, that's just what I had to say. Thank you.
Thank you. Yeah, I see some pros with safety, sense of anonymity, and then a negative piece is the privacy, reliability, lack of resources, right? it can provide a fast way to information, Cheryl shares too, while avoiding face-to-face contact. So sometimes it's harder to be in those face-to-face situations, but you need to get the information, or you want to get the information, right? Tony brings up a great point about a lack of privacy, because many people live in multi-generational households, and you may not know, if you're providing telehealth, you may not know who's listening in. You may not know the context of which someone is receiving the information. Is someone just out of frame? Are you speaking into a room where multiple people can listen in on the conversation? Is it a truly private interchange or not? And I saw earlier, you know, the point is that during these times when there are lockdowns and prohibitions on seeing people face to face, it actually was a way that people got some sort of support. I do know in the field that there is still a strong emphasis and import placed on face-to-face interactions and developing relationships in person. But telehealth is starting to be a way to connect with younger generations that are more comfortable using technology, as well as connect with people that may not be able to travel or may not be able to spend the time to get to a face-to-face interaction. Imelda has some great ones too. It's adapting to this new normal. A challenge means, you know, the individual may not have access to electronics, or may have limited airtime or cellular use. And sometimes even getting folks connected to technology can be really difficult. So great thoughts. I think that it's really important as we go through this is to hold out, you know, the reasons why we think that, you know, telehealth does have a place in advocacy, but recognize that it may not solve all of our issues, and it may not work for all survivors. I think it's something that a lot of agencies are now adding as an add-on. As Carmela mentioned, a lot of folks will start with initial in-person discussions and then provide online advocacy, telehealth, chat, email, other ways of connecting with survivors for follow-up. Also, you can use telehealth and chat for different purposes, such as we're looking at prevention and education. If a survivor, you want to, you know, introduce the survivor to meditation or mindfulness practice, providing access to some of those online resources might be really powerful. It's not the same as providing direct therapy or talk therapy to a survivor, but it is a way of providing education and supportive services to survivors that doesn't require them being in the office with you. So, I mean, the reason to make sure that our work includes a recognition of online advocacy and the importance of it is that the studies are really showing that telehealth services do work. They may not work quite as well as the face-to-face situation for all survivors, but they do work. A recent study that compared teletherapy to in-person therapy found that 96% of telepsychotherapy patients were satisfied with their online sessions, and they showed significant improvement on pre and post sessions for their mental health screenings. So we're seeing that it does actually affect people's mood, affects their coping strategies, and does provide support services. And the in-person clients actually showed no significant change after their sessions, whereas the folks that got the telehealth services did show an improvement. It's one study, but it does point to this working and this helping survivors, and maybe helping some survivors more than in-person therapy can. It also increases access to services. So especially in rural areas or in areas where there's limited transportation, or given that there's COVID-19 movement restrictions, this increases services to anyone who can have access to technology. Some of the most basic technology is just regular phone service, but then it goes up if you can get connected to broadband and Wi-Fi. You can do the online services, or do a download of videos, mindfulness videos or support videos. It also may lower the costs for survivors and for the agency. We're seeing now that agencies are grappling with a work at home situation where maybe their brick and mortar agencies aren't being used in the same way anymore. This lowers the cost for the agency. The other way it lowers costs for survivors is maybe a survivor can do a 30-minute session on their lunch break and then go back to work because they don't have to drive all the way to the agency for the consultation, the intake or the meeting. They can do it from their home. And then the basic technology that's needed is becoming more and more widely available. We definitely still see a digital divide. We see a divide based on race and socioeconomic level, and who has access to fast internet and who doesn't. And then we might even have geographical issues. I'm not sure about how good what the broadband is throughout Guam, but I'm sure there are areas where it's not as good as other areas. So that is a geographical issue too. Some people may not have access to that technology in the same way. But I feel that still we are advocating for intentional use of telehealth in our work. And I think our services have always had online / telehealth piece to it, because of so much of our services had started around 24-hour hotlines and call-in services, which are forms of telehealth. We need this intentionality because we're seeing now that our agencies and our services have to adjust given times of crisis and shutdown. We need to address gaps in access to services. And that's why in rural areas, people have been working on issues of telehealth for a long time. Another area that has a lot of information around telehealth is our military. They've been providing various different forms of telehealth to their veterans as well as their active service folks through in different countries for years. So there, and Guam I know is very closely connected with the military there. So there's a wealth of knowledge around telehealth services and working with military and various other agencies on Guam. There's also a decreased time frame for providing services. So telehealth is really great in providing immediate help. That is why our crisis lines are sometimes the first place people go, because they're allowed to call 24 hours a day, 7 days a week, and get immediate contact and support. And then we also need to be intentional because we need to maintain our relationships. So in times of isolation, it's important for us to be creative and think about ways to expand our services, expand our advocacy, expand our reach. And I think what has scared many or been worrisome for many folks is that worry that telehealth and online advocacy will reduce confidentiality. We are seeing in practice, there are many ways to protect confidentiality and privileged communications through online advocacy. So it's not necessarily true that all forms of online advocacy would breach confidentiality. There are ways to protect it, and we'll talk about that coming up as well. So I think we may have already answered, some people may have already answered this, but what are our shared experiences with telehealth and technology in responding to sexual assault survivors? I already saw some folks mention, talking to people on crisis line and providing them with support services or like self-help resources. Any other examples that you may have experienced? I'll just make sure we'll talk about all these, but a way to consider our history with advocacy through telehealth and using technology is our long history of using telephones as a way to connect. We now are using emails as ways to provide support services, maybe not direct services for survivors, but also services that coordinate response with law enforcement, that coordinate responses with health practitioners. We're using technology in a lot of ways to increase our communications. It sounds like perhaps some folks are providing video conferences, and they're providing possibly, social media outlets for education and prevention. And Imelda, has a really great point that, especially with the issue of sexual assault, there are some people that will never report. We know that the reporting level for sexual violence is very low, and that, it's estimated 80% of people that have experienced sexual violence never report it because of the shame and humiliation that is kind of surrounded sexual violence. It also is a hard thing to talk about face to face with people, and other people finding the filter or the screen as a way to step back from the intensity of a person-to-person reaction can really find telehealth to be therapeutic, able to talk about what's happening to them. Right. And denial is another, issue with sexual violence because of the huge stigma associated with it. It is very hard to admit that or to talk about what had happened to them. Telehealth allows for people to maybe even start to to lean into personal healing, but also just to engage in conversation without having to out themselves out as a survivor of sexual violence. They can be part of a conversation, be part of a knowledge exchange, and to start to kind of be able to find healing in those ways. So telehealth really helps people access information, and that is good for all survivors. So I want to share a video from the US Surgeon General, because I think it just shows that you should be encouraged to take on telehealth, that the US government is very pro telehealth, especially in the current COVID-19 situation, and that there are 4 or 5 great little practices around providing telehealth to make you feel secure and comfortable using these forms of technology. So let me cue up this video.
The COVID is altering almost all aspects of American life. During this emergency, we've seen a dramatic rise in the use of telehealth. Hi, I'm United States Surgeon General Dr. Jerome Adams, and here are 5 things to know about telehealth services. First, telehealth visits are safe. Virtual appointments lower the risk of spreading the virus among both the general population and healthcare teams. Second, telehealth enables those who are vulnerable to the coronavirus, like the elderly and those with compromised immune systems, to continue receiving some medical care safely and without office visits. Third, Medicare allows payments for telehealth services for beneficiaries wherever they are, even in their own homes. Prior to the COVID-19 public health emergency, Medicare telehealth services were only available to people when they were in a rural area and at a healthcare setting like a hospital or physician's office. Fourth, telehealth visits protect patients' privacy and personal health information. HHS has made it easier for providers to offer telehealth services through commonly used technology while still maintaining guardrails to ensure privacy and protection of patients' sensitive health information. And fifth, telehealth is likely here to stay. Of course, there will always be a need for in-person visits, but remote consultations are convenient and are the very definition of patient-centered care. State and federal laws will need to adapt post-COVID to ensure the continued smooth delivery of telehealth for both patients and healthcare providers. To learn more about how telehealth services can facilitate safe and convenient care, clinicians and patients should go to telehealth.hhs.gov.
So I wanted to share that just because it shows that the US government is behind the increasing access through telehealth, that it is an accepted practice for even the most sensitive, confidential information about patient health. You have to take precautions, you have to actively protect that, but it is becoming more and widely spread and accepted as a form of support services and as a way of connecting folks with help and support. Great. So we know it's going to be here to stay. What I wanted to do next was ask you about anonymously. So what I love about these polls is they're also anonymous. So if you would share what types of telehealth is your agency using? I'm going to launch that poll now. And if you could just go ahead and pick which types of telehealth your agency is using in providing support services or education or prevention or communications. If you're only able to choose one, just pick the one you're using the most. Great. I'm seeing a trend. I think this trend actually reflects a lot of what I've seen in California as well. Great. I'm going to give it just a couple more seconds and then I'll share our results. Okay, with about 60% of us reporting, we see that phones are first, with emails coming in second, and then video conferences. And then I'm seeing some more use of social media and even virtual reality. So we're seeing some use of social media, especially around prevention and education, but they also are ways for survivors to reach out and ask for help and support. And there are ways and protocols you can have for your Facebook page, for your Instagram feed, to be able to process direct messages where survivors may be reaching out for help, and agencies should be prepared to respond to those in a way that protects patient and survivor confidentiality. So maybe if a survivor posted something on your Facebook page asking for help, instead of responding back in the feed, you would direct message that survivor with information of or a warm referral to services. So there's lots of ways to use social media, and virtual reality is going to be a leading edge around support and therapy. Some of the possibilities around virtual reality is creating more of a reality-based setting where people are feeling like they're in the same room with someone, or there's ways of doing motion therapy and different ways of connecting people to their body where they're guided through virtual reality. So that's some leading edge areas I think could be used therapeutically for survivors going forward. Great. So it looks like we're using our phone, which is probably one of the oldest ways to support survivors in crisis. Our hotlines have a long history of being open and being avenues for survivors to get support services, as well as for people that love survivors to connect to information. Now in COVID-19, we're seeing that video calls and face-to-face interactions through technology are starting to take the place of some of our face-to-face in-person actions. Video calls are unique in that they do provide, like video calls and phone calls provide real-time feedback. So you are in a real-time conversation. Online chat or messaging is a different sort of feedback. One is it's not necessarily visual, it's text-based. And also there's a lag between when information is given and then when there's a response back, which can be good, it can have negative and positive. But some survivors would prefer that, prefer to have a conversation stretch over a period of time instead of being on in a face-to-face where it's a very intense interaction. Email, similarly, is a form of more longhand messaging back and forth. So it's more of like the antiquated letter writing, where you put more information in your email and you wait for more information to come back. And then there's shared files and videos. That leans more to communication, prevention, and education in providing with survivors with what we call asynchronous opportunities. Asynchronous education. As a mother of four, I'm very comfortable with it now, is instruction that's happening independently of kind of direct contact or supervision or teaching or education. So it's watching a video, maybe filling out some questions on your own versus being in a conversation with someone. And then there's a lot of mental health care apps that are coming out too, ways to track your mood, your feelings, and then also there's physical health care apps that track your heart rate, blood pressure, sugar levels. So we see app-based technology also growing for both mental health and physical health. So we want to have a kind of fun video that talks about video conference telehealth best practices that I want to share with you. And what I'd like you to do is, take a look at this video and, highlight, think about which do's and don'ts stick out to you the most from this video. Here we go.
Yeah, I don't know. I'm supposed to be doing a televideo at 2 o'clock. It's like 6 minutes after, and it's to Mariposa. I'm not even sure exactly where they are, but I can tell you that they are always late. That's the one thing I know as to where they are. So I don't know. I may bail after another 5. Yeah.
Dr. Goldblum, actually,
Yeah.
Mariposa can see you. You're on their camera and they can hear you.
Hi, Dr. Goldblum here. You must be Ken. No, you must be Phil. Hi, Phil. I'm Dr. David Goldblum, and I'm your consultant today on televideo. Can you hear me? Can you see me? I'm right here. Right? You got it? Okay, good. Okay, let's get going. So Phil, before we get started, let me explain a little bit about confidentiality. First of all, this is a secure transmission line, and what we're about to discuss is entirely confidential, with almost no exceptions, unless there's a danger to it.
I forgot to clear up.
Oh, hi, Supaneet. How you doing?
Sorry about that. I'll let you continue.
Oh, no problem. Great to see you. Gee, I feel like we need to get caught up. Anyway, so it's completely confidential, and Supaneet, sorry, but I think you forgot that this is yours. I'm pretty sure that this is yours. So be sure to take that with you, okay?
Thanks.
Great to see you. All right, I got to get back to work.
Bye.
Right. Well, look, Phil. Let me try to summarize for you what I think is going on in what you've told me. Ever since that incident in the coal mine, you've been struggling with a depression. I think that has not been adequately diagnosed, or treated. So I think what we need to do is think about a treatment plan that could help you to. Just sit tight for 1 second. Dr. Goldblum? Yeah, I'm kind of in the middle of something. Well, I obviously can't see the car when it's up on the hoist, so you tell me if the tires look bad. You know, I got them last season. Look, I'm in the middle of something quite important, okay? I'll call you back. Thank you very much. Sorry. Hello there, I'm Dr. David Goldblum. You may be going through your first experience with televideo, and I want to welcome you to the new technology. Just as long as you can see me clearly, then it's going to be as if I'm right here in the office with you. So, I heard you were having a little trouble seeing me before, but I hope that this way you get a better sense at least of what I look like and how I'm reacting to what it is you're telling me.
Hi there. Are you Penelope Waters?
Yes.
Hi, I'm Dr. Allison Crawford. I'm the psychiatrist who's going to be speaking with you today. Nice to meet you. I just want to tell you, I understand this is your first time meeting with somebody by televideo, so I just want to explain a few things about the process. One of the first things we do is always make sure that we're speaking to the right person. So you're Penelope Waters?
Yes.
And can you just confirm your date of birth for me?
Yes. September 17th, 1976.
Okay, great. Well, it's a pleasure to speak with you. We always make sure that people understand that although I'm speaking to you by camera, nothing's being recorded right now. And this is just as confidential as if you were in my office with me. So there's no one else in the office with me, and we make sure that no one else can hear what we're speaking about.
Excellent.
Okay, and at the end of our session, I'll be sending a note to your doctor.
Okay, great.
Okay. I also, you might see me, I have a remote control here, which allows me to zoom in and out. And you have the same thing there. So if there's something that's not clear to you, or you want to zoom in on me or zoom out, then you can do that with the remote control.
Okay.
Okay, great. Do you have any questions?
No.
Okay, and if at any point you get upset or you need anything, you can always go back and speak with the nurse who brought you into the room. Okay, we can pause at any time.
Okay, thanks.
Great, well, let's get started. Can you tell me a bit about yourself, like what town you're in, who you live with?
Yeah, I'm from Mariposa, and right now I'm living with my sister.
Okay, great, and are you working right now?
Yeah.
I like this video because it highlights some of the do's and don'ts. What did you see? What were some of the do's that you saw at the end, and what were some of the don'ts that you saw in the beginning? I do think there is something to the sensitivity and the stigma of sexual violence, and there are situations where some survivors are going to respond to online services more positively. Yes, exactly, Taylor. The first guy was very distracted and there was no security. I had to smile because it's like kind of funny how blatant it is, but he was saying it's a secure conversation and then someone just walked right in behind him. So make sure that your space as a professional is prevented from being interrupted, your cell phone's off, people aren't, coming into your video, coming into your room. Recognize that even the that cracked me up. That the cell phone came on. This is not a confidential communication, so having a dog come in or something like that is totally acceptable. But in a confidential communication where you're talking with survivors, you want to make sure that those type of distractions are not going to take your attention away or appear to be taking it away. Another thing that's really important is that if you have
questions I'm just going to ask you just like at the clinic, and then once we're done with the questions, I'll be out to take your temperature and then provide you sanitizer. You come in.
Sorry, I was trying to find the mute button. It's important to just be able to also protect the communication, and that means not recording it, not taking, just the same as in-person advocacy, you don't want to take direct notes, verbatim notes. You want to just take what you professionally need to take for notes, and you want to protect the space. So that means that you have doors closed, you have a sign up, do not disturb, and that people don't even come in to the space, even if they're not on video. You don't want them overhearing. It's also important to check in with the survivor to make sure that they are in a safe or comfortable space, and maybe even provide for a code word or kind of escape button mode if the space they're in suddenly became unsafe. Say that you're talking to a domestic violence survivor who still lives with the person that's causing them harm, and suddenly that person comes home from work and they need to get off the call immediately. Talk to your survivors and your clients about those pieces so that they have an understanding of how they can walk away and protect themselves and have a plan for those type of things. Just like we have emergency escape buttons on a lot of our websites so that people could always get out of there quickly if they need to. Bring that same kind of safety button approach to your online services. Anyone else notice anything? Oh, I have a few that I'm missing down here. Right. And it really does, the distractions and the non-professionalism, such as eating, chewing, makes survivors feel like they're not worth the person's time, that they're not being respected. And that's another way of like re-victimizing survivors after they have already been victimized. I think that setting up expectations was a really good pro that they showed, a do. She talked about the technology. She even like explained the remote control situation that was happening between the two conference call rooms, acknowledged that people might need to walk away or they may need help or support, and that they can pause the session at any time. And, I think that just showing that professionalism and setting up expectations is really, really important. And these things can't be kind of created on the fly. I think it's important for agencies to have a script or to have like a bullet point list of how they open up their telehealth online advocacy, letting them know the limits of confidentiality. It's like, say that the conversation is confidential, but you're not talking to a therapist. So in Guam, it may not be a privileged communication. That means that although you're going to do everything you can to protect the communication and not share it, that a judge could still compel disclosure, or an attorney could try and get that information disclosed. So it's not as fully protected as other forms of, such as patient-client, or doctor-patient confidentiality, or attorney-client confidentiality, where a judge would have to make a finding in order to disclose anything that happened in those conversations. So just being realistic about the level of confidentiality, having a shared code word or a code action, even a signal. Like maybe it's not cupcake or whatever, but maybe if she just holds up 2 fingers like this, you know, okay, my husband just came home, I need to end the session. And you just carefully close that out and you have a shared understanding about that. And I think you have to find a way to be present in a way that is not rushing. Just like Margaret said, you can't rush the communication and just get the information you need to get. Most of our stances as advocates is listening. So you need to create the trust that you're listening and you're going to be present there. And you can show that in different ways. Do know that some of the things that I'm going to share as best practices may not be as culturally relevant for Guam, and you may want to make adaptations to these. But being able to be seen, being non-distracted, making the appropriate level of eye contact or looking away, being professionally dressed, it all signals that you're providing time and space for the survivor and that they are important. Those are all those non-verbal cues that really, really can start to build relationships. All right, let's head back to the PowerPoint. I also found a very good call screening for practitioners on domestic violence that I want to share with you in a few minutes. But next, I wanted to talk a little bit more about face-to-face video calls, conference calls, and making sure that you have good protocols in place for these video calls. The difference between video calls from other forms of telehealth are they are physically, there is a face-to-face aspect. That means they're in real time. And if technology is working appropriately, you can see the person's face. For these type of situations, you might want to have a protocol or understanding about people taking their video off. When you take the video off in video call situations, you're not able to read that body language anymore. So you're losing a little bit of the tools of a video call. People may be more comfortable with a phone call if they don't want to have to share their screen, if their internet isn't strong enough, or if they don't have access to other forms of technology. It's very important when providing therapeutic work and support work to not record sessions, because anything you record could really become evidence. So it's important not to just over record therapeutic sessions. That's a breach of confidentiality and should only be used in like education and prevention settings, such as this web conference. Recording this web conference makes sense because we're using it to educate beyond the moment, and there's no confidential information we're sharing. It's more information going out. But recording a person-to-person therapy session can be harmful for survivors by creating evidence that really shouldn't exist. And then I would say that it's important to check your encryption, billing records, and other identifying information when you're using programs like Skype and FaceTime and Zoom to see kind of what information is gathered both by your agency or your provider and what may be gathered by the survivor's provider. When you look at cases of domestic violence and stalking, you can see that looking at billing records, that people that abuse often look at billing records to determine, who has the survivor been talking to in order to get control, and it can lead to escalation of violence. So being just realistic about what information your agency and your provider is collecting and what information the survivor's provider is collecting is important. And then do that great verification of a survivor or client. You can use code words built into the verification. Two-piece verification is what most medical providers require. So like first and last name, and street, something that just identifies that the person is the right person that you're supposed to be talking to. And then another thing is you can build in a certain code word or to make sure that we're okay to have the session still. So it could be like, this is not very coded, but you could be like, still a green light. Is it still a green light? And then the person can say it's a yellow light or a red light. And you would know, okay, that means that maybe someone is home that could overhear. So we might not be talking about, might not have the full confidentiality, or it's a red light and we need to reschedule the call. So building in a way to check in with people, realizing that when you're not in the same room with a door, you don't have control of the other person's context. Figure out ways to work around that for video calls. And talk to your survivor and clients about that. They'll help you get creative about what would work best for them. Another form of online technology and telehealth that is becoming more and more widespread is online chat and messaging. And I differentiate between online chat and messaging because they kind of have two different shelf lives. Online chat are conversations over an online messaging service that's housed on a web browser. So I know that's a lot of like technical jargon, but what that really means is that you're using an app like WhatsApp or you're using Messenger to relay messages back and forth. And there's a record being kept on both sides. So both people using the app have access to that script, the transcript. That means that it's not as confidential as other forms of messaging and connection. Online chat is, online messaging. Actually, I was describing online messaging. Online messaging is app to app based. Online chat is when the conversation is held on a website. That is actually a higher level of confidentiality. So the higher level of confidentiality is that this other survivor does not have an automatically downloaded transcript of the conversation. They, of course, could take screenshots of it. There are different ways of capturing it from the other computer, but you're not automatically saving a history. Versus using like text chat on your phone is you're able to see long strands of conversation. You keep both sides of the conversation, and that becomes could be dangerous for exposure and could breach confidentiality. So online chat is this browser-based messaging service. It really came out of working with customer service providers. Maybe many of you have been on websites now, and you'll see something pop up in the corner that says, customer service representative ready to chat or help. That's what I'm talking about with online chat. It's run through a website and it's staffed by a consumer advocate. We're seeing that sexual assault and domestic violence agencies are using online chat more and more to provide a real-time conversation. It is in real time, but there is a delay between answer and response. It's not as immediate as a phone call. The online messaging is what we're most commonly connected with for text messaging. So this is our texting format. And that's a conversation that goes back and forth, and it can be over a long period of time. If you look at maybe your text chat history with a family member, you can see that the period of time for your conversation may be months or years if you look back the entire transcript. You need to check encryption and recording and the records created when you're using text messages for sensitive information. And basically advocates are, we point to online chat as a better option than online messaging or texting back and forth because of the dual records that are created when you start a conversation through text. Since the chat is recorded on both sides of the conversation, each device has its own record. While you at the agency on your agency phone may have control over that, you have no control over the other side of that the survivor may have. So just common, being able to provide real-time text-based conversations can be very valuable. You need to be careful as an agency about how you set that up and make sure that you're trying to have the most confidential setup as possible. That really is looking more like online chat versus text-based online messaging. Email. So we, in our work lives, we use email a lot. We use it for education, to fill out our reports, to share information with colleagues, to connect with our families, send pictures. We use email in a lot of different ways, but it may be more difficult to keep confidential to the level of that maybe survivors want, because again, like the text messaging, the emails are saved on both sides of the conversation. So it's important that we need to check again encryption and the clearing of emails and what kind of policies we have around what we store in our agencies for email. We need a confidentiality provision at the bottom of emails so that there's an expectation that we are going to protect confidential communications to the level that we can. That just provides a safety measure if an email got into the wrong hands. If you had the confidentiality provision at the bottom, it means that you could argue that it couldn't be used or it wasn't an inadvertent disclosure because you had that confidentiality. So it may not be the best form for counseling, although it can be useful for education and exposure to asynchronous learning and that kind of piece. But I would be very cautious about sending personally identifying information or confidential information via email. And also remember that writing can be a therapeutic practice for survivors, but writing into technology creates a footprint that they may not be able to erase. So while they may want to email out their entire story, as an advocate, you want to make sure they are stepping into that with a full knowledge of what the implications could be if that email did get into hands that they didn't want it to be in. And then finally, but next, we have our good old phone. Phone calls are our oldest form of telehealth, and they have been really important for responding to sexual violence and domestic violence since the beginning. A lot of things in the United States started with a telephone that was manned by volunteers, and it became a way that people were able to reach out for help and support no matter what time without calling police directly. And then given our phones and how they've changed, we're seeing more and more digital-based and internet-based phone services now. So again, remember the need to check about encryption and about the history and billing contact information, so you know what type of information is being saved to your phone bill. It's just important to know that, not saying that no information should be gathered, but it's important to know what level of information and to remove or purge history as appropriate, not necessarily keep files for years and years and years. Things become part of a record and can be exposed to breach of confidentiality if they're not protected, and if you as an agency don't kind of understand the amount of information you're gathering and don't have a reason for gathering the information. Again and again, judges will point to, what would a professional person do? Is it necessary to do your work? Connect and keep the information that's necessary for doing your work. You don't need to keep extraneous information. And next is shared files and videos. So this is a growing area for prevention and education and self-help, using these asynchronous materials. Use encryption, password protect, and use data security tools. And if these feel like jibber jabber, talk to the people that work in IT or your IT service provider and ask them, like, what's the level of encryption and what does that mean? Have a process of changing your passwords regularly. And, you know, understand the data security tools you have within your agency. Time out access to confidential information. Some rape crisis centers in California are using cloud-based data servers to store confidential information, and they need to make sure that that access doesn't linger on a laptop or from home. They need to make sure that the access is timed out. And don't allow sensitive information to be downloaded to personal devices. So now that things become cloud-based, it becomes really easy to save it down to your laptop or save it down to your phone. You need to set up a policy and protocol so that personally identified information doesn't bridge into the personal, onto a personal device or personal information gathering. And then really key to this working well with shared videos and files is providing employee training on the proper use of shared files and protecting confidential information, you know, such as the timeout access, not leaving sensitive information on personal devices or public devices, and taking active measures to change passwords and protect confidential information. And finally, use care when recommending videos and other asynchronous materials. Do a trauma-informed check. Would a survivor be triggered by this information? Is this too graphic or too detailed for someone just to process on their own? Make sure that the asynchronous materials make sense for the survivor. I think that shared videos and files can be really, really powerful, but they have to be used with a trauma-informed lens. All right, we kind of didn't get quite far enough, but I do want to give you a 10-minute break because I know it's the beginning of your morning. So let's end there with the shared files and videos and take a 10-minute break and come back at 10:35. So take a break, stretch, relax, and I'll see you back here at 10:35. All right. I hope everyone was able to take a little stretch, grab some water. I wanted to kind of finish this review of modalities of online healthcare with an exploration of mental health apps, which are becoming another tool for supporting people in their mental health. And it becomes a place where you can track and monitor changes. We see that clinical therapists are using these type of apps, especially when someone may not be able to make as many sessions as they may need. And that could be because of finances, because of time away, and just the cost of the resource dependency that needing to go to sessions takes, in-person sessions. It also promotes self-awareness and self-management strategies. And so I wanted to show you a great article I found that does a review of the 2020 mental health apps that are used both in clinical and non-clinical settings. And I'll make sure that you have access to this website as well. But I think it's just important to acknowledge that technology is changing the ways that we can support individuals' mental health. And although it may not take the place of in-person support, this SciComm article does a review of various different ways to help do safety planning, struggling teenager support for young people, What's Up, which is a ACT therapy method for depression, anxiety, and stress, Mood Kit. There's even a series of addiction apps which help people self-monitor and regulate addiction and patterns of addiction, and anti-anxiety, such as Mindshift, which is a great app designed to support mindfulness and de-escalate anxiety. So apps may be another way of providing online advocacy and telehealth, and it might be something interesting to look into to providing survivors. I know that I recommend like meditation apps to survivors often as ways to provide peace and quiet, time to center on their own thoughts and be able to find peace and to calm anxiety. So using apps might be part of this new future, much like in the dating apps, we now have all these apps helping us find romantic connections. We also have apps that can help us with our mental health. So before we move into a more detailed look at confidentiality, privilege, and providing support to survivors, I wanted to share 2 more videos with you. One is about screening for domestic violence. It is written from the perspective of a health practitioner that is working through telehealth to support survivors of domestic violence. But I thought it would be helpful for you, given the various backgrounds. So if you're working with someone who may be a survivor of domestic violence or may be in an abusive situation, give you some tools and tips for supporting them through telehealth. Okay, here we go.
Training for domestic violence during a telehealth call, brought to you by SafeWorks. As many have seen in the news, with the rise of COVID-19, there has also been an increase in reports of domestic violence. Experts are now calling domestic violence the secondary pandemic. One of our greatest concerns with COVID-19 is that so many survivors are now isolated at home. The abuser may be experiencing additional risk factors that we associate with lethality. This includes unemployment, escalated substance use, depression, and other things that we know can compound an already delicate situation. It is not uncommon for victims to seek refuge when going to healthcare treatment. Although telehealth offers an array of benefits to patients and physicians, for domestic violence victims, it is complex at best. In the era of telemedicine, confidentiality cannot always be assured. Phone calls and video chats are not necessarily private, and victims of domestic violence may not be able to voice their concerns from home. As a healthcare provider, it is always your goal to do best by your patient. So right now, you may be wondering, as a healthcare provider, what can I do to help? When conducting telehealth visits, a healthcare provider needs to look for nonverbal cues. This can include the inability to answer questions, unable to explain how they got injuries or bruises, little to no eye contact, looking around the room, and even the partner pacing in the background or sitting directly with the patient. In addition to watching for nonverbal cues, it's also very important that we recognize universal signs. Many social media platforms have been sharing secret words and code signals. One of the most common one is when a person puts their hand up to show you 5 fingers and slowly transitions the hand to making a number 4. The other hand signal is a person that shows their hand with a black dot in the middle of it. Although these hand signals do not tell you how to proceed, they do alert the provider to the fact that there are concerns in the home. It is crucial that you as a healthcare provider never assume it is a safe time to talk about domestic violence via a telehealth call. The abuser or small children may be in earshot of the patient. It is also important to not use standardized screening tools that you may have used during your in-person practice. If you engage in either of these activities, you may unintentionally cause harm to the patient. At this point, you may be wondering what you can do if you believe your patient is in an abusive relationship. Thankfully, Safe Berks is here to help you. It has been determined that at this point, the most effective and safest way to provide support to victims of domestic violence is to provide universal education to all of your patients. At the end of every visit, you may have to say something like, "Many of my patients have been experiencing hardships during this time. I'm going to put a list of community resources on the screen. You can reach out to them at your convenience, and if you need help with that, you can email me." Then provide the directory of community resources on the screen. If you need help identifying those community resources, Safe Berks would be happy to help you. If possible, this may be a good time to ask the patient to come in for their next appointment. This is a great time to talk with the patient privately about any concerns that you may have. If you need additional assistance with this, Safe Berks medical advocates would be more than happy to be available at the in-person appointment. Safe Berks medical advocates can provide information about Safe Berks services, as well as other community resources. We can also take the time to safety plan with that patient if at that point they are not ready to leave yet. When medical advocates are present, clients are much more likely to utilize services. If you have additional questions, concerns, or would like a medical advocate present for your next appointment, please contact Macy Javeras, the Director of Medical Advocacy at Safe Berks, via phone 484-869-5294 or email at macyl@safeberks.org.
So that's a great example of a community outreach video that promotes universal education, universal resource distribution, and could be created for your locality in Guam and used to educate healthcare providers. I also really like how it talks about some universal signs that survivors of domestic violence or people that are in abusive situations are using, both this signal of 5 and slowly moving to 4, or a signal of having a black mark on their palm. These are just different visual cues, or you can think about having personalized code words or conversation with your clients about how they want to let them know how safe they are during the telehealth support services. I wanted to share a couple other videos just that give you an idea of kind of the commonality of using telehealth for services. One is a lot of advocates are moving towards saying nurses are using telehealth in rural settings in the United States for a long time. And here's a little information about that.
And to help victims of sexual assault. Launching their Safe T program last year with Penn State, the number of victims that have come forward has nearly tripled from the previous year. One of the sexual assault nurse examiners, or SANE nurses as they're called, says that they know they're changing lives when working with their patients, but wish the victims didn't have to go through that trauma.
You get to know them a little bit as you're doing the exam and talking to them and changing their attitude from when they arrive tearful, upset, and so confused and overwhelmed to having a plan of action and giving them some control over the situation at the end.
The Safe T protocol includes victim advocates, the DA's office, local law enforcement to help the patient after leaving the hospital.
So that's really interesting. They actually are using, with Penn State, they're using a video camera and monitor. Nurses have an advocate present with a survivor during the exam. So that's the innovation that's happening and has led to even more, more medical exams, more people coming forward, and maybe even increased prosecution rates. And then I wanted to share one more kind of overview of mental health with you, as far as like a educational video that you can share. As always, I've included these in the end slide. And this is geared around mental health care online options in telehealth, but it will intersect a lot with survivor support services.
Hi, Dr. Alexander. It's great to check in with you again. I've been practicing the strategies we discussed in my last appointment, and they seem to be helping. Thank you.
I started using an app to track my feelings and emotions, and I share this information with my therapist. It helps both of us understand my progress and identify the next steps in my treatment plan.
I wanted to know more about my daughter's recent diagnosis. Her therapist recommended educational videos that I could watch online. I found them very helpful in understanding my daughter's treatment plan and supporting her recovery journey.
「 Advocacy 」 Advocacy を 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 Advocacy These are just a few of the many ways that technology can be used to help in mental health education, care, and treatment. These new digital options for accessing health services, monitoring treatment, and finding information on health topics and healthcare all fall under the umbrella of telehealth. Technologies used in telehealth include apps for smartphones and tablets, video conferencing, educational videos and websites, and online patient portals. For men and women who find it difficult to travel to and from a doctor's office, telehealth may be an affordable, accessible alternative.
When we moved out to the country, I realized that it would take me more than an hour to drive to the nearest mental health professional. I went to my primary care doctor, and he was able to recommend a telehealth psychiatrist. Now, my psychiatrist and I use video chatting for some of our appointments or texting when I need more immediate care. I can even meet her in person when I need a face-to-face session.
Telehealth tools can also support in-person treatment.
I feel like my mental health app helps me work toward my treatment goals. It allows my therapist and me a better understanding of what triggers my symptoms and helps me keep track of my therapy homework.
People may find that telehealth tools help them feel less alone and more empowered when experiencing mental health issues.
My daughter's therapist was glad to hear that I felt more prepared as a caregiver after watching videos about my daughter's mental health issues and learning more about how to support her.
When deciding if online mental health care options might work in your treatment plan, you should also be aware of the potential drawbacks. There may be additional costs as well as privacy concerns when using telehealth services. Talk to your healthcare provider to learn more. Cost considerations for telehealth may include the cost of phones, computers, and high-speed internet. If you decide to move forward with telehealth services, such as treatment, team appointments, or sharing your health information, talk to your healthcare provider about the privacy of your information. Be sure there are data privacy protections in place so that the healthcare information you share over the internet is not accessible to others. It is important for you to carefully weigh the benefits and drawbacks of telehealth services. Let's hear more from men and women who use telehealth services.
It has been a lifesaver to be able to talk to Dr. Alexander on my laptop when I feel my symptoms coming on, rather than having to miss time from work to drive over an hour to her office.
Using the app has made my recovery journey a part of my everyday life instead of something I only work on during my appointments.
The online videos have really helped me feel like an important part of my daughter's healthcare team and treatment journey.
The use of telehealth technologies in combination with traditional care is one way to bring you, your support network, and your treatment team together to support you and treat mental health needs.
Let me just close that. So I like that one also. It's a great educational piece that urges us as survivors and as advocates to help people weigh the drawbacks and the positives for telehealth and maybe come up with some sort of hybrid way to provide support with online advocacy and in person when we're able. So as they mentioned, that security issue is one of those that always lingers around confidential, sensitive information. I wanted to spend a little time talking about confidentiality, privileged communications, and telehealth, and underscore that there are ways to be mindful about online advocacy that does protect confidential and sensitive information. In general, confidentiality is a value of sexual assault survivor services, and it's required under the requirements of the Violence Against Women Act and the Victims of Crime Act. So especially when talking about services that are funded by those acts, agencies are encouraged to keep sensitive information as confidential as required by the jurisdictional laws. Privileged communications are a subsection of communications that are protected by laws in the jurisdiction that prevent disclosure of information. Guam does not have a sexual assault counselor privilege like they have in California, but there is attorney-client privilege, there is doctor-patient privilege, therapist, patient privileges that add another layer of protection to communications. Then organizational policies and protocols need to outline confidentiality protections, but they need to make sure that they're outlining the technology confidentiality protections, not just assuming that everything is in a face-to-face conversation or situation, making sure that technology is protected. And we'll talk about what that means. It means a lot of these kind of jargony terms, but I'm gonna just leave them with you. Make sure that you can have a conversation with the people that run your internet, that run your technology. If you're privileged enough to have an IT team, have a conversation about the ways that you're protecting information. What is the level of encryption? And encryption is a method where information is converted into a code that hides the true meaning of the information and unlocked with a key, like a digital key to decode it. Again, as a general requirement for sensitive information, do not over record, either through audio, visual, and or written. And then make sure things are password protected. And it's important that passwords are not password. Hope no one's password is password anymore, but make sure that it's a password that's difficult to guess and that it's not written on a Post-it right by your computer. So figuring out a way to have your passwords be memorable, but also not easily seen or discoverable. And then finally, creating confidential spaces and rooms. That can mean locking up physical files. It can mean having a locked office where you do your in-person video conference advocacy. It can mean having an encrypted iCloud folder where it's password protected. Finding ways to protect the communication or the information that is being shared over telehealth and online advocacy. Another really important piece of confidentiality is that expectations are set, that there's an expectation of confidentiality, and that people understand that there's an attempt to create confidential space. That also means that limits are discussed. So as a mandated reporter, you're trying to create a confidential space, but best practice is also to disclose that there are limits to your confidentiality, such as if a person is going to harm themselves or others, or if there's a child that is being abused or neglected. Making sure expectations are set about the services that a person can provide, and that the level a person can protect confidentiality and privilege. So, whether a confidentiality protection is a little less strong than a privilege protection, that means that confidentiality is just, we're going to have the practice of keeping sensitive information sensitive. We're not going to be talking or sharing that information outside of workspace. And then there's a time frame for getting back to the client, especially when working with online advocacy tools such as online chat, which again is when someone's chatting through a website, or if you're using messaging or email, or even if people are leaving phone messages. Make sure that there's an express or expectation around how long it will take to get back to the client or survivor. That will be key in building trust and communication. Every agency that is working under the Violence Against Women Act, the Victims of Crime Act, or has other requirements to keep confidentiality needs a procedure that outlines how information is protected and that employees are trained on that. And then there also needs to be an expectation of actively taking steps to protect information. Before technology, before online advocacy, this has been through physically locking something. Now we use the lock and key of encryption and password protection. So I wanted to do just a quick breakout room. We're not going to be able to do it for as long as I was hoping, but I'm going to put you all into breakout rooms of about 5 or 6 folks. And I'd like you to think about how you and or your agency have actively taken steps to protect various forms of technology, such as phone lines, computer files, cloud stored information, video calls, online chat, text, and emails. And be sure and let me know if I've not included a form of technology you are using. But I would like you all to have a conversation about how are you taking steps to protect these types of this type of information and sensitive confidential information. 1 minute. We'll recreate our breakout rooms. Okay, I'm going to give you 10 minutes to talk about that. I'm going to try and put it in the chat really quickly. I'm not going to list all the examples, but how technology. And here we go. I'll give a broadcast when we're about 2 minutes out from closing them. See you in about 10 minutes. Health and technology and education, and it will give you a good idea about the level of protection, whether they are certified compliant with both of those laws. Online chat, it's important to regularly clean the conversations and the histories unless there's a professional reason to keep those records. Don't keep the records for no reason or under no guidance. Like, you don't want to keep a record forever. You want to be able to archive and purge files. Text is important to clean the conversations and make sure that the expectation is set. If you're sharing sensitive information over text, realize that there are 2 copies of that information. Similarly with email, make sure you have that confidentiality note on the bottom of your email if your agency is supposed to be complying with confidentiality requirements, so that if your email gets inadvertently shared or forwarded, you have some level of protection that says that the expectation was set that this was confidential. And then be sure to think about how your agency enforces people to change their passwords and how difficult to guess those passwords are for everything from phones to computers and other devices or technology you may be having staff use. It's important to kind of have a more rigorous password program for your agency. Some agencies have people change it every 3 months. Other agencies require, a special character, number, and capitalization. So it's not just a single lowercase word that's easier to guess. So those are some of the best practices we've heard from technology experts and people working to protect confidential and privileged communications. Shared those with you, and I have some resources and memo that I'll share at the end as well that provides more information about it. Again, techsafety.org is a great resource for this for domestic violence and sexual assault agencies. So moving on to best practices, we got a little bit of a preview of this from our video. But with phone lines and computer files, stored information, video calls, online chat, text messages, they need to be addressed in your policy. So your policy should acknowledge if confidential information is being shared technologies, and then have a way of protecting it or mention it. Shouldn't just be silent, it should be mentioned. For video and in-person or video connected best practices, make sure there's privacy, make sure the noise level is low, and you have control, whether that's through a mic or other way of not shouting it across multiple rooms. Visual distractions, reduce the visual distractions, make it a calming backdrop as much as possible. Have appropriate lighting, which I found difficult doing this from California, and my son's already down. The sun is already down here. Trying to make sure my lighting is, I'm practicing what I'm preaching with good lighting. Make sure your clothing is professional, not in pajamas, not wearing pants, like any of those kind of things. You want to have a professional appearance when providing online advocacy and telehealth advocacy. And then eye contact. Of course, there is always cultural considerations with all these things, and you need to adopt the cultural norms and talk about what those expectations and body language are, and figure out how to demonstrate that you're present for the survivor in these online face-to-face interactions. Make sure that encryption is checked, HIPAA and FERPA compliance, password protected. Your organizational policy names forms of technology and includes others. So technology constantly changes. One of the best practices is to not necessarily name individual technologies, but include a catch-all for new technologies that may be developed. Who knew that Twitter was going to take over so many folks' lives? And who knew that Zoom was going to become like a household name? Make sure that your policy reflects and has room for changing times, and that you review your policy. I recommend that organizations review their policy around confidentiality and technology annually if possible, or every 2 years. So I'm wondering if anyone feels a little more personally ready to do telehealth. I'm going to relaunch this poll and see. All right, now that we've entered the end of the presentation, how ready are you personally? to expand your work into online advocacy and telehealth? All right, I'll give it a couple more seconds. Great, great. So I think we've moved the needle a little bit. I think more people are in the middle now, getting ready to try telehealth, to not only in the face-to-face therapy situations, but also in prevention, education, and communication. Using these online tools, maybe using some of the videos we've shared or other tools you learned from this web series to provide education and support to community members and to survivors, and to provide some of that universal education, especially around issues of domestic violence and sexual assault right now. The more universal education we can give to everyone, the more chance that folks understand their community resources. And then finally, I wanted to see if you think you're organizationally ready anymore. How ready do you think your organization can be to expand to telehealth? Do you think maybe you recognize that your organization is already doing some of these things that you didn't consider telehealth? Most advocate agencies run a 24-hour hotline, which is a form of telehealth. It's the original telephone form of telehealth. Great. I think this might have skewed a little bit to improvement as well. I'm seeing that we've moved from 0% ready, so we had more of a chunk of organizations not ready at all, to more in the middle, to the lukewarm to warm area of being ready to incorporate telehealth. And I must say, I mean, I love technology. I think that there are many benefits to it. I don't think it replaces person-to-person connection, but I do think it can help. And I do think, especially for millennials I work with, young people I work with, their relationship to technology is different than my relationship to it. And bringing in a realness that we can provide really good services with technology. We don't have to do everything the old-fashioned way all the time. Is a way to reach more survivors, and to really bring in young people into our work. So thank you all for your participation in that poll. And in summary, I wanted to just recognize that the studies are showing it works. It's a way, it may not be perfect. It may not work the same as in person for every survivor, but for some survivors, it may work better than in person. It can be confidential and protected communication. We're getting all the cues from the Surgeon General's office, from the VOCA and VAWA funds, that confidentiality is important, and the use of technology can be included in confidential protected communications. There's best practices that exist. There's spaces to learn and grow in providing online advocacy. And this can be more efficient and more affordable for both agencies and also for survivors. It may be able for them to have a weekly session with online advocacy, whereas if they were doing in person, they could only meet once a month. So it's a way to actually increase communication and connection with survivors. And especially during these times, uncertain times, increasing that protection in a time when they're isolated and maybe even isolated with someone that is causing them harm. CalCASA has created telehealth memorandums. These are connected to California law, but include various best practices that apply to all the jurisdictions, US jurisdictions, and can be adapted and used as a resource. I also wanted to share and quickly show you the Pacific Basin Telehealth Resource Center has a series of videos, series of resources that were really excellent and are targeted towards island communities and Guam in particular. So let me escape out of this and show you that website so you can kind of have a familiarity with it. I was in, they, oh, I'm going to go to it really quick. So this is, if you're an agency that is moving into telehealth care or support, this is specific for the Pacific Basin and housed in the University of Hawaii. They have some telehealth care best practices, short information video, what to expect from a telehealth visit, and this really nice quick guide start to starting telehealth services during COVID-19. So make sure you take a chance to check out those resources. There might be even more educational sources for you there. And they're specifically created within the Pacific Basin and hopefully relevant and connected to the services you have, you're providing and to your community. And then I finally wanted to share also, I think that it's very interesting, the history of our military and telehealth care. They've been working in telehealth care for a long time. The Veterans Affairs Pacific Islands Healthcare System with this website has a lot of resources around telehealth care also that can inform and may be able to support, or maybe you all are already working with these healthcare systems and maybe you haven't realized how much telehealth care interests and online advocacy interests you may share. Here's a list of video resources we used during this session. And I'll pause here for any questions. I'll make sure that Shelby forwards the memo on telehealth as well. I urge you to check out techsafety.org. I'll put that in the website, in the chat again for you, if you want some like great resources geared specifically towards domestic violence and sexual assault both. And you can click through there to see their best practices and tools. And just as a reminder, I'll leave it to Shelby and these final web conferences that are coming up in November and December. It's really been my pleasure to be part of this series with y'all.
Yes, thank you so much, Emily. So as you guys can see, these are some of the next upcoming webinars. So the next one will be actually tomorrow, November 19th, and that one's going to be on ending tech abuse across generations. And one of CalCASA's staff members, Ashley Klein, actually will be our presenter for that one. And then you'll also be back with her on December 2nd and December 3rd. So do look out for the information on these and be sure to register. And similar to the November web conferences, for the December web conferences, if you are interested in getting the CEUs, continuing education units, then you would have to attend all December sessions. So yes, we thank you all for staying here until the end of the session. Emily did give out a lot of gems and a lot of resources. So definitely do use those. And if there's not anything else, then we can end the session a little bit early today. Nice, okay. Everyone's saying thank you to Emily. So thank you again, Emily. And thank you to you all for being here. And have a great rest of your day. Okay, I'm gonna end the session now. Bye, everyone.